My name is Arthur Rocha and I work in Professor Carnevale's team at the Hospital das Clínicas, Brazil. I'm an engineer and PhD candidate in medical radiology. In the past few years, we have developed an optimized imaging workflow for prostatic artery embolization. Historically, PAE imaging workflow was completely based on a 45-degree oblique DSA imaging to understand the anatomy and help plan PAE strategy. The optimized workflow we have developed and published establishes CBCT from the internal iliac artery as the main imaging and the use of embolization planning and guidance software such as Embo ASSIST from GE to improve anatomy assessment and PAE planning and navigation. The key advantage of CBCT and Embo ASSIST is to help assess the prostatic arterial anatomy, which, as you know, is complex and variable. It avoids misleading identification of the origin of the prostatic artery, which would make navigation difficult. It also helps confirm whether a branch is a secondary prostatic artery that we need to embolize or a branch going to a non-target organ like rectum or others that we should avoid. At SIR 2020, we presented the results of a study showing that CBCT was superior to DSA in identifying prostatic arteries in 46% of the cases. And when used, Embo ASSIST allowed further identification of the prostatic arteries in almost half of the cases compared to CBCT. The objective of our latest study is to update the PAE anatomical standards published by Dr. Assis in 2015. Since then, we've routinely adopted the optimized imaging workflow using CBCT and Embo ASSIST. In 2015, the study based on DSA found that only 80% of the hemipelvis had multiple prostatic feeders. We recently analyzed all PAEs performed between 2017 and 2021 with CBCT acquired from the internal iliac arteries. We have found that the anatomical types prevalence was similar to what is described in the literature. However, and that's important, almost 1/3 of the hemipelvis analyzed had at least one secondary prostatic branch, which is significantly higher than the 8% previously identified on DSA alone. So based on CBCT, we found almost 4 times more secondary arteries than previously described, based on DSA only, which are important to embolize to reduce the incidence of revascularization, and we believe to reduce LUTS symptoms recurrence after PAE. Routine use of CBCT is key for a complete prostatic vascular anatomical understanding. With DSA only, you could miss 3 out of 4 secondary prostatic branches, which are an important cause of symptoms recurrence after PAE. So we recommend routine use of CBCT imaging with augmented planning and guidance software to improve PAE outcomes.